Welcome to a special episode of Startup Health Now, the weekly show celebrating the healthcare transformers and changemakers reimagining healthcare. My name is Stephen Krein.
And I'm Unity Stokes.
And on a special episode today, supported by a grant from the Robert Wood Johnson Foundation, we're going to sit down with Margaret Laws from the California Healthcare Foundation and talk about how to inspire entrepreneurs to focus on opportunities to bring their innovations to underserved communities. This is going to be a great episode.
Stick around.
It is the duty of leaders to lead, of the creative to create, of the daring to do. The free world expects leadership of us. Its fate and our fate depends upon our leadership. We are industrious, inventive, restless, with the fires that burn within us. But I say that nothing is easy, and the best things are the hardest. And all our troubles, all our immense difficulties, now and in the future, can I say, be solved if we have the will, the courage. The future is to those who take it.
Welcome back to Startup Health Now, the weekly show celebrating the healthcare transformers and changemakers reimagining healthcare. We're excited to be sitting here with Margaret Laws from the California Healthcare Foundation and a longtime supporter of Startup Health. Welcome to the show.
Thanks so much. Excited to be here.
Well, welcome back to New York. So I'd love to start just by framing the discussion with more about you and your background. You got a background in public policy, but would love to learn also about California Healthcare Foundation and the mission there as well.
Sure. Let me start with that. California Healthcare Foundation is a private nonprofit foundation. We're based in Oakland, California. We've been around since 1996. And we do about $33 million a year in grants and projects, all of which is really trying to focus on improving healthcare for the people of California with a big focus on low-income people. We have four program areas, one of which I lead, Innovations for the Underserved. And in the Innovations program, we have both a grants component and an investment fund. And through our investment fund, we're looking to invest in companies, early stage healthcare companies, that we think can dramatically improve access to care, dramatically reduce cost of care, or both. So we're working with now 9 companies, 1 nonprofit and 8 for-profits. We started the program in 2010. And that was actually really probably what got us connected initially with Startup Health, was this effort to try to help bring entrepreneurial companies into healthcare with a real specific focus on helping those entrepreneurs should they be interested in meeting the needs of underserved populations.
So do you work with all stages of companies, or is it mainly at the early stage? Tell us a little bit about the types of entrepreneurs that you're working with.
Well, it's a good question, and it's been evolving. So this was an experiment. We started in 2010, and we were really trying to sort of test the hypothesis that a foundation, with the relationships that we have in policy, the relationships that we have with providers, community health centers, public hospitals, community hospitals, would really be able to play a role, to fill a niche in this sort of ecosystem of bringing early stage companies or later stage companies into the healthcare safety net. So we've got a range in the portfolio right now. One of the companies that's actually a startup health company, Direct Dermatology, was and is an early stage company really focused on the healthcare safety net, but growing in multiple states now and growing pretty rapidly. Others we actually invest in a little bit later. We might be investing alongside venture funds in something as late as a Series C or D, but often in an A or B round. And there we're usually putting in very specific money and making very specific efforts to bring a company that's got some commercial traction or some commercial success into the healthcare safety net. So we try to leverage our understanding of Medicaid policy, reimbursement, of workflow and the EHR environment in safety net providers. We use that term usually when we're talking about community health centers, public hospitals, community hospitals, other places that serve a lot of low-income patients. So as I said, we try to bring that specialized knowledge to ecosystems like Startup Health to try to help make the market between companies and this part of the market that often doesn't get to work with innovative companies.
So I'm excited to dig into the entrepreneurs and the companies, but I want to actually back up on you. I want to back up on you because of your background, what not only you did before you got here, but what you specifically your unique ability as a California Healthcare Foundation.
So I've been at CHCF for a really long time. I actually started there almost at the beginning of the foundation. It started in '96. I came in '98. Prior to that, I had worked in management consulting, both on the strategy and government practices in Accenture, Anderson Consulting at the time. I had worked in the World Health Organization in the Global Program on AIDS. I'd worked in state government in Massachusetts, and I'd worked in a couple nonprofits. I did a public policy degree at the Kennedy School, and while I was there, did quite a bit of work in both the business school and the School of Public Health. So my goal has been sort of career-wise to try to bring all of these different sectors together. And the opportunity that I've had at CHCF, I think you mentioned this earlier, I initially started out running the policy program there and really getting pretty deeply familiar with the regulation in healthcare, how state and federal government is involved, and how, you know, the regulatory environment that companies face. But always had an interest in health IT and kind of the business of healthcare. So at the foundation, I've really been able to bring together policy experience working with nonprofit and for-profit companies, the consulting work, looking at new markets and understanding what it takes to enter them, bring that all together and try to actually bring the best parts of the public sector, private sector, and nonprofit sectors together to try to transform healthcare. So
the public, private, large company, small company, entrepreneur-driven early stage startups, all the way through to working with large organizations. Your kind of arc at the California Healthcare Foundation has been unique around obviously now focusing with and spending time with entrepreneurs. Just want to bridge now to a little bit about what you're doing on a day-to-day basis with the entrepreneurs. You talk about 9 companies now. What are you doing to help them specifically, and how are you spending your time?
Great. No, great question. And it's actually been, as I said, this ongoing 4-year experiment and really exciting stuff. So I now have 2 people on staff and a consultant, and among us we're working with these 8 or 9 companies. And what we're doing on a day-to-day basis is actually, it's always an interesting conversation, because people ask us, well, once you make the investment, you know, you're done, right? You've made the investment in the company, they can go do their thing. And we say, no.
It's kind of like when an entrepreneur raises money, they've done. It's like, just getting started.
That's when it really begins. And so I'd categorize it I put it in a few different categories. So one category, which as you guys know, and certainly everyone in this startup health ecosystem knows, is customer identification. So really helping these companies both identify and understand and get together with potential customers. So we spend a lot of our time out in the healthcare safety net with clinics, with hospitals, with medical groups, really understanding what their innovation needs are. And what's a little bit different about the way our program works is we're really driven not by what we think is the neatest, coolest, most innovative idea necessarily, but by those innovative, great ideas that actually match a need in the California safety net.
Can you back up on safety net? Because I want to explain that to the listeners for people who don't understand what a safety net is.
So, you know, we use that term, it's not, there's no strict definition for it, and think of it as the healthcare providers that serve low-income people. And in the U.S., those tend to be a whole group of clinics called community health centers that have some federal funding attached to them. They're specifically funded by the federal government to serve low-income, both Medicaid covered and uninsured. Undocumented people often get their care there as well. There are public hospitals, which are often county hospitals, but they're sort of the providers of last resort, the big county systems. And then there's rural and other providers who, by virtue of the fact that they're in a place where there are no other options, are serving a lot of low-income people. A lot of medical practices as well. So in California, even though we deliver primary care through clinics, we've also got small medical practices and larger medical practices that are focused on Medi-Cal or focused on the low-income patients.
So what are the big needs of the safety net today? What are you seeing that maybe to frame it a little better, that entrepreneurs should maybe be focusing on, so the big problems that more entrepreneurs should be paying attention to for the safety net?
Well, there's we're sort of at a moment in time with the passage of the ACA and a lot of newly covered people coming into the system, a system that, you guys know wasn't really ready to take on millions of more people. So the first one, and it's a really big one, is efficiency and access. So how do you actually take the resources that we have out there in the healthcare system and effectively deliver right time, right place, right care to more people? And that might mean virtual care, that might mean delivering care with different kinds of workforce teams or personnel. So I think some of these new care models that really focus on how you get more out of a clinic or a system, how you're able to get more people the care that they need for the same amount of resources.
So can you pick an example of maybe a company that is serving that need?
Well, let's actually use Direct Dermatology because
Perfect.
they're a startup health company. Direct Dermatology, so big problem with access to dermatology.
Dr. Wong.
David Wong. Big problem with access to dermatology for you and me, but especially if you're low income and especially if you live in certain geographies. So in California, the Central Valley, it's a big farm farming area, big farm worker area. There are very, very few dermatologists out there. And the ones that are there often don't take Medicaid. And so if you're a low-income person working in the Central Valley, you're out in the sun all day long, you don't really have any options for getting dermatology care. And what was happening out there was people were waiting 6 to 12 months for a consult.
And that's the difference of maybe life and death for some people.
It can be for skin cancer. And so what David Wong did with Direct Dermatology was said, look, we're rotating. He was a Stanford doc. He was rotating through the Central Valley, seeing these patients, and he couldn't figure out why. He and his partner couldn't figure out why they were seeing all of these conditions in the hospital that really should have been handled in primary care. And they realized there isn't any primary care dermatology. Yep. So they basically set up an affordable. They did a couple things. They thought, okay, what's an affordable price point for this? They set a price point of around $85, and they said if we can deliver this virtually. They send us a picture, we review the picture, we send them back a treatment protocol. That would be great. We get lots more people seen. We could potentially catch the things that might be serious. We can really help triage and get the right people in to see the dermatologist. And so they created a model, and one of the things they had to think about was how do you actually make it cost less? So how do you create a lower overhead model of a specialist office? So
I have a quick question while you're talking about this is, because you introduced us to David early on. How many of the entrepreneurs come to you with this already figured out, this gap, versus you actually helping lead them a little bit towards the opportunity to make such a big impact?
We've been, by and large, we've been looking for lots of reasons, which we can talk about because I think it's relevant to this discussion. We've been looking for people who have gone so far as to identify a need and test it out a little bit. So for us, it's a really important factor that we see in someone, because we're going to invest a huge amount of time in them, and we'll get back to sort of how we're spending our time with them. But we're going to invest a huge amount of our time. We're going to put them in touch with our contacts. We're going to leverage our relationships. And so we want it to be someone who has actually had the curiosity and the drive and the energy to actually go out and say, I've identified a problem, and I may not have created the solution yet, but I've actually tested a solution on, in this market. And so I think that can happen in lots of different ways. That can happen because you're, like David, a doctor in practice. Right. It can happen because you have been, working at a clinic and you've observed something that's
are there more physicians and people and clinicians coming to you with these ideas and these kind of early startups, or is there any characteristics that kind of, you can start to see a pattern of the kinds of companies that are already working in this area?
No, so I would say there's a few categories. So one is the clinician, and someone who's been working in the system and has identified a need. And we've actually done a lot of work to actually help clinicians in California through some fellowship programs we have learn innovation methodology, so that if you're one of the doctors working at San Francisco General Hospital, you've been trained to be a doctor, we provide you some training to do innovation needs finding, or to use user-centered design, to use some of the things that will help you potentially uncover a need that you might meet through an innovative startup. The second category of people are people who have a personal or family experience that they're responding to. Right. And as you guys know, you talk to all of them as well, there's a huge number of those. And the third category, I would say, are people who are coming over either from consumer or tech, typically. They're coming from another market. It's often informed by a personal experience or family experience they've had, but they want to try to apply something that an insight that they've had or something that they've learned in consumer or tech to healthcare. So
you just described a lot of just broad entrepreneurs in healthcare, right? Because these are these buckets. But I think it's interesting that there are those that are directly aligning themselves with the safety net, that are being, the whole entire value proposition is zeroed in on this. Are you seeing them come to you directly with that, framed because they know maybe you are already focused on it, or do you see them? Yeah,
people who are doing that will usually find us, and it's a really interesting question, because I think my personal perspective is that someone who has a idea that has the potential to be broadly successful across both the safety net and commercial market probably has a better shot at having a successful company. Somebody who is there only because of a safety net need, it may be very hard to find a successful business model there. It's not true everywhere. There are some parts of the safety net and of the payer profile and landscape where you can do that. But by and large, to have a big enough market for something to be broadly successful, you want to see it meet a need. And these are human needs. The need for dermatology care is not necessarily differentiated, nor is the need necessarily for prenatal reminders for prenatal care. The environments in which you incorporate and kind of integrate the technology or the company are different, and I think that's where we can be the most helpful. So we sort of want to take asthma, dermatology, asthma, any of these things, diabetes. We're very interested in areas that disproportionately affect low-income people, but they affect high-income people
so
as well.
It's one part of their strategy, but not the strategy.
Exactly.
So as you sort of think about the opportunity for these entrepreneurs that are focusing on the safety net and underserved communities, what really is the opportunity for them? I feel like there's a lot of fallacies out there. There's a lot of misconceptions. Entrepreneurs maybe think they either don't understand how they can develop a business that focuses on the safety net, or they just think, oh, I just need pilot programs and think about it randomly and go after the big hospitals or the whatever. What are the real opportunities that entrepreneurs should be focused on?
Well, I think one thing that differentiates the safety net from the commercial market, though it's not black and white, is a much higher. A much lower tolerance for high-cost things, right? So to the extent that you're developing a low-cost solution to something, whether it's a blood test or a dermatology consult or, a messaging platform, that's going to be resonant in the safety net. And one of the things that, if you've got a premium product or something that's very high-end, or a technology solution that costs $100,000 or $200,000 or $300,000 to implement, it's likely not gonna ever take hold there. So one of the first things I think about is, are you really genuinely looking to do something that is good or better quality but low cost? So is the kind of the lens you're bringing to it, how can we make this affordable? And so to the extent that you're really driven by taking something and making it affordable, that's a good profile for something that could work in the safety net.
And what do you see as the business models that are, where's the money coming from to support these programs? So you take, David Wong and an $85 snapshot on your iPhone. How does this translate into money and the flow of money?
Yeah, so it's a complicated question and a topic for another whole.
So just generalize it. Yeah.
So generalizing, let's think about the Medicaid program. So most low-income people who have coverage, with the exception of people who are lower income people covered under the exchange, but the lowest income people in the country are covered by the Medicaid program. The Medicaid program is funded about half by the federal government and half by the state governments. So every state government has programs they deliver either through managed care or through a fee-for-service program. So if I'm an entrepreneur and I'm thinking about, okay, let's say the problem I want to think about is how to address asthma in kids or adults who are on Medicaid. One of the things that I really have to be thinking about is, how does Medicaid pay for asthma now? And where are the pain points? So one of the pain points is that people spend a lot of time in the emergency department. So really understanding sort of the impact of these conditions on how the expenses fall out in the system is really important.
Right.
So I think
historically, knowing now how it works, but it's obviously changing.
Right. And that's a really interesting point, because California, where I am, happens to be almost all managed care now. And so now, which is a good thing, we're getting into sort of a more value-focused environment where a managed care plan is thinking, what's the total cost of care for someone? So a managed care plan might be thinking in a very different way than it used to think.
Bundles.
Because before it used to think about, well, I won't get paid unless this person comes into the office. And so everything has to be an office visit. But actually, virtual care, telephone care, video
saves
care.
everybody time and money and frees up the room. Yep.
As long as you're as long as you're not being paid for the person to come to the room.
That's the shift, the fee for service.
And that's the shift that we're seeing.
Value-based care.
Yeah, so I think the challenge for entrepreneurs now, or for anybody working in healthcare now, is we have sort of a foot in each camp. And we're moving towards more value-based care, but a lot of the safety net is still about a visit in a clinic. So a lot of the work we've been doing has been trying to work with that whole sector, the clinics, and help them incorporate some of these new models of care and really think through. I mean, again, so you asked earlier, and now I'll bring it in there. So what we can do to help entrepreneurs is say, look, we understand how that financing path works. So if you have something that we think can be better for patients, better for providers, provide better care, keep people out of the emergency room, all those things that are good, then we can help you figure out how does it get paid for.
I'm sorry.
No, go ahead.
I was going to try to unpack this down to some maybe some practical advice that we could share with entrepreneurs on because you mentioned a lot of really interesting things about how you're developing your product, how you're thinking about your pricing, how you're thinking about your solution. What sort of practical advice, or what do you tell entrepreneurs that are focusing on solutions for underserved communities?
So I'll give a really practical one, and I think this is what CHCF uses, but I think it's probably a useful exercise for anybody in startup health to go through, or any entrepreneur that's looking to get in this market. And we say that the metrics we're trying to hit are $25 million annually of cost savings in California, and or new access, or much better access for 100,000 people. So what we ask the entrepreneur...
So $25 million in savings.
Annually, yep. Or new or much more timely access for 100,000 people. And California's a big state.
That's the impact. That's both social and financial impact you're looking to make.
Exactly.
Okay.
And so what we do is we say, one of the things we want an entrepreneur to be able to do is have a really solid hypothesis about how that's going to happen. And it gets to this question of,
it's a big question.
What is social value? So what is your hypothesis about how this is going to save $25 million?
How many people walk in with that?
Well, we tell them in advance. But it's a great point, and I think people don't. And what I would say is, in some ways, I don't necessarily need someone to have figured it out, but I need them to have thought about it.
Sure.
Yeah.
So I want them to have thought about how many people are there with asthma, how many people have diabetes, how many how many dermatologist visits are there a year, So you want them to be thinking, and I think anyone is capable of this. They might need help, or they might need some guidance or mentoring, but to really break down the problem and say, if I'm coming into this world saying I want to have social impact, to really be able to sort of articulate a hypothesis about what that social impact is going to be.
That's great.
I think that's really important. So that's my biggest piece of practical advice is to have thought through that question, and to have thought through it with some numbers and with some data and with some facts. Because I think just seeing people being both curious and rigorous enough to do that, because this is hard.
Sure, and you're doing it just in California. Do you have other colleagues across the country at other foundations, other states that are thinking the same way, both as innovatively and as concrete as you are with numbers that entrepreneurs can hang their hat on?
Yeah. We've been talking to a number of foundations about it, and the Kresge Foundation is now co-investing with us. I think that everyone we talk to, and I will just say that the 25 million and 100,000, while we didn't completely pull them out of a hat, they're not scientific.
Yeah, I was going to ask you.
For us, what they were was, it was, from a conversation that I was having with my, former CEO when we were just conceiving of this program, and saying, what would be something that would be big enough in order of magnitude to be meaningful, to be impactful? And 100,000 lives has been a 100,000 lives campaign. 100,000, even when there are 39 million people in the state, is it's big. A lot of times things foundations do or other investors do only touch thousands of people. The 25 million was really something we picked as kind of an order of magnitude. If we could get that kind of savings, even though we have a almost $100 billion Medicaid program in California, that would be meaningful.
So it's still tiny, but it's concrete enough for the entrepreneur to kind of figure out how their programs, their solution scales.
Right, and it's shocking, given how tiny it is, how hard it still is.
Yeah.
And we track it. So as we go through, we go through the work with our companies over the years, we're tracking their progress towards those
What's
numbers.
another example of a company that's doing well with the, making progress towards those numbers?
So we have a company called Pipeline RX, and it's a company that does virtual pharmacy oversight. So when you're in a hospital and you're an inpatient, before you get given any medication, by a nurse or a doctor, typically a pharmacist is supposed to review that order to make sure it's the right dose, to make sure it's not the wrong medicine, all those things. Many hospitals, and there's a law actually that they have to have 24/7 oversight. Many hospitals don't do it, and they fulfill that retroactively or in different ways. And what we looked at there was what are the costs in terms of errors and staff time that can be avoided by virtualizing this. So what Pipeline RX does is it has teams of pharmacists who virtually work in those hospitals. So it's as if they were in the basement of the hospitals filling the orders. They're in the hospital's system. They're in their pharmacy information system, but they're doing it remotely.
So they're able to do it the same way David Wong is able to look at a picture of a mole or a rash.
Yeah. And there, as opposed to what we're measuring with David, which is how many people are getting dermatology care in 2 days instead of 6 months or a year. We can measure that pretty concretely. We can also measure the costs of them not having lots of treatments that don't work and potentially getting skin cancer. But in the case of Pipeline RX, we're measuring staff time, staff cost reductions, and we're measuring error reductions. And they can actually quantify and have quantified the errors. They know the errors they catch and what those are worth.
And so you're getting them to think early on about measuring and validating and using data. I think it's one of the hardest parts about being an entrepreneur, I think, in this sector is the need to continue to bring that data back to get the next pilot program, the next customer, and really do that. So you're providing them a great service by getting them focused on something so measurable and clear.
So if you could wave a magic wand and there were certain types of solutions or innovations that you guys were coming across, what would those be? Or is that the way you look for innovation? Or it's whatever comes over the transom and you pick the best ones?
No, it's actually interesting. We've started to, we've taken a at least quasi-scientific approach all along, where we've gone out to the safety net and we've said, what are your needs? Our needs are for access to specialty. Our needs are for more efficiency, getting people through the clinic. Our needs are for chronic disease management programs that lower income people can use. Some of the biggest challenges are electronic health record integration. And so one of the challenges in being in this digital health space is that all providers, safety net providers like everyone else, because of incentives from the federal government and just because of where we are in the technology adoption cycle, have fairly recently adopted electronic health records. And a lot of the things that entrepreneurs are building need to somehow interface with those. They need to share data back and forth with them. They need to populate them. And that's a really hard problem. And it's a hard problem across the board, but it's a particularly hard problem in the safety net because you don't have the kind of an IT team in a safety net institution. So to some questions we've talked about before.
Maybe this is an advantage because you got to develop a solution that doesn't require a whole IT team.
Right. That's true. It makes it harder to pilot. It makes it harder to get people to take the time and the person power to get a pilot done. So it's one of the challenges and why it's hard, that there isn't a team there that can work with the entrepreneur to say, let's think about how these two things work together. And sadly, because I kind of agree with you, for a while what we thought was, well, let's just look at things that don't need to integrate with the EHR. Right. But these providers, having spent so much time getting these EHRs in place, don't have a lot of patience anymore for opening 6 other windows.
It's got to fit into everything's got to fit into the workflow. We're seeing that.
And so workflow, I would say, I think that's a better way of characterizing it. So let's go back to one of your questions. Understanding the workflow of a provider is a very concrete, when you ask for concrete examples. And so how do you do that? You might go spend some time in a community health center, shadowing or working there. This is the nitty-gritty part of being an entrepreneur, is sort of figuring out how do I make myself unobtrusive enough but valuable enough to actually get some experience understanding the workflow of this place.
How receptive are these organizations to working with entrepreneurs, to maybe doing pilot programs, to letting them shadow and learn? how hard is it for an entrepreneur to get in and start working with one of these organizations?
You know, it's tricky. And one of the things we've done, we basically fund an organization called Center for Care Innovations. And one of the things that we did through our CCI relationship was fund something called Innovation Hubs in the Safety Net, which I think is an idea that could be expanded around the country that would be great, where we basically provided some foundation support for those safety net organizations to become innovation hubs and to pilot and test.
So you're giving them money?
Mm-hmm.
Are you teaching them how to
Both.
think more entrepreneurial
So we're doing
and open to being startup friendly?
The whole gamut.
Yeah.
So they're getting some money, and then they're basically, getting training, in innovation methodology. So in anything from user-centered design thinking to the Stanford biodesign process, but really helping find catalysts within those safety net organizations. And our whole history of doing this, which goes way back beyond the fund, has involved us as a foundation supporting people in the safety net to play that role. Because I think if you don't do that, it's very hard for them to take the time. They're already working.
They're strapped.
They're really strapped, and so thinking about ways to create opportunities for those safety net providers to actually get something back. We actually, just as an example, about 4 or 5 years ago, we put 6 safety net clinicians through the Stanford a mini version of the Stanford biodesign process. It was great. Professional development for them, and it made them receptive hosts to teams of innovators. And so I think to answer your question, it's not a natural, easy fit, but I think there's appetite, and I think with some support, we can create more. I think of these as vectors, and we can create more of these vectors.
Who are some model examples of organizations within the safety nets that are just doing a terrific job of opening up their minds to working with startups and entrepreneurs?
So, one of our great partners is San Francisco General Hospital. So the big public hospital in San Francisco. We just have a terrific team of people there, many of whom have gone through CHCF's leadership program. It's a 2-year program we put clinicians through, a couple of whom went through the biodesign program, but a group of whom are just really, really enthusiastic about creating a culture of innovation. So San Francisco General is one of the hubs. San Mateo Medical Center has been another terrific one. We hear great things about Montefiore. We haven't worked with them out here. Denver Health is really a model system where they've done a lot of work in lean. So there are public systems, both clinics and hospitals around the country who are really eager to try to innovate. I think the nut to crack and the tricky thing for getting especially entrepreneurs without a lot of experience in healthcare is to figure out how to create win-wins.
Yeah, where everybody wins. Well, I mean, the whole, the grant that we received from the Robert Wood Johnson Foundation for this idea that we want to inspire entrepreneurs to, understand and look towards and actually go towards opportunities to help underserved communities, we think is incredibly important. I know you're an expert advisor to the program that we've developed with the Robert Wood Johnson Foundation. We really appreciate that. What would you say, or what do you say to entrepreneurs that just are getting started and trying to figure out how to start? Where to start? What do you tell them?
Well, before I answer that question, I would say it just was interesting to hear you talk about what the focus of the Robert Wood Johnson Foundation program is, because I think that there's a piece of it that could some of that resource be used, or could additional resources be brought to bear to sort of prime some more safety net institutions?
Yes. Yep.
I think that would be a huge compliment. And if I would say we had one really big lesson learned at CHCF, it's that we have to spend at least as much time working and getting the safety net ready as we do.
That's why some of our questions were around that, because we're hearing from the entrepreneurs that, and this is, I think, one of the reasons we started Startup Health and created this platform was knew it was important to build a peer network of entrepreneurs. You need to have a stakeholder network that is leaning in, batteries included, lots of energy, want to work with the entrepreneurs. And if there's anything right now that there's not enough of, it's just enough organizations really culturally from the top down.
It's growing.
Yeah, it's growing, but you need more, as you said. So I'm glad you brought that up, because I think that balance and that need to do both sides is important. It's not just getting the entrepreneurs to see the opportunities.
Yeah. So back to your question about the entrepreneurs. I mean, I would say a couple things. I would say do your homework. I don't think nobody wants someone coming in who hasn't explored the question. So, use resources online, understand who the population is, understand what languages people speak. Kind of try to have thought through that piece of it. So I want to help people. I want to help people with diabetes. I want to help low-income mothers. Understand those populations and kind of do your homework there. I think one of the biggest pieces of advice I would give, and it goes exactly to what we were just talking about, which is hard, is to try to spend some time in the environment. Yeah. So if you haven't worked in a clinic or community health center or anywhere where low-income people, go volunteer. Yeah. They'll take volunteers. And even, when you're a smart person who has a technology background or a consumer background, you can go spend some time in a setting, whether it's a hospital setting or a community health center setting, and probably have an incredible set of takeaways that could be very valuable to those organizations. So I think doing that background, doing that homework, I do think, and I was talking to someone on the phone the other day about this, I do think that one of the great things about the incubator and accelerator programs is that they give people the opportunity, they give people sort of a stamp and an opportunity to connect with mentors who are from those organizations. So I know, I think that's really important, is to the extent that you can get into a situation where maybe you volunteer with Startup Health or volunteer with one of the other incubators or accelerators and get to know some of the mentors. Yep. I don't...
So you're self-selecting through people who are already identified as they want to lean in and help entrepreneurs.
Yeah. Try to find healthcare providers who maybe your peers or friends who work in those settings, and interview them. Yeah.
It's interesting. How many of the teams, out of curiosity, because we're seeing a lot more now. I think probably 40 to 50% of the entrepreneurs in our program or startups in our program have clinicians as part of the founding teams. How many of the founding teams are coming in with that clinical experience?
I think at least half.
Yeah.
And
which is crazy, by the way. If you think back even like 5 or 10 years ago, doctors and other clinicians were not becoming entrepreneurs or joining startups.
Right. And I think that there's actually, these programs that bring in doctors. I don't know whether Startup Health has done one yet, but I know others have, where, you do an event to bring in doctors who are interested in innovation and give the entrepreneurs or the would-be entrepreneurs opportunities to interact with them. But I think you kind of hit the nail on the head, and we talked about it a little bit earlier. Understand the needs from the perspective of the people working in the system. And you may have a great idea, and even if your idea is the greatest idea in the world, it probably needs to be molded a little bit or modulated to meet those needs.
So one last question. Where are we in the state of things? What are your predictions for how things are evolving, and some of these big challenges for the underserved are being resolved or solved? Do you feel like we're making progress? How do you feel?
I do. I mean, what I would say, and I've said this a lot in conversations over the past couple months, is I think there's been a sea change over the past 2 to 3 years. I think knowing that the ACA was coming, knowing that they were going to need to serve more people, knowing that there were going to be people who actually have choices about where they go, has really gotten a lot of safety net providers thinking hard about how do we make the system work better for people? How do we make it more patient? How do we really flip the way we've thought about healthcare from designed however it's designed, and if people use it, great, and if not, it's not our fault, to how do we actually think about it the way we think about the rest of the world? How do we think about making it service-oriented, patient-centric, really meet people's needs, rather than sort of saying, boy, if people can't figure this out, that's their problem. And I think that has shifted dramatically, and I think the ethos of what you want to be as a system has changed. And I think that's very much in the safety net. That's exciting.
Yeah, and we're just getting started. So if you were to choose one word to kind of sum up how you're feeling, what would you say?
I'm excited. I'm really excited about making this match. I'm really excited about bringing innovation into the safety net. And I think this, I'm excited that it's finally a time when we're sort of, knocking on the door and people are really excited about opening it, rather than kind of looking at us like, I'm not quite sure, we don't want to know because it's something historically it's been, we don't want to know because we know we can't do it. Yeah. Now we're getting people saying we want to try that.
And we need to try that.
And we need to try it. And that's exciting.
Well, Margaret, first of all, thank you so much for spending time with us today. Thanks for what you're really doing to help us with the Robert Wood Johnson Foundation program to help open up entrepreneurs' minds and inspire them to focus on underserved communities. And most of all, we honestly use your name often as an example of the type of person and the type of organization that is leaning in to help startups. You've done it from the beginning. You were instrumental in helping us launch Startup Health, and I really appreciate everything you do. I know that your name comes back to us often as somebody who is just kind with their time, very helpful to entrepreneurs, and the spirit of what you're doing at the California Healthcare Foundation is incredible, but what you do personally to network and spend time with the entrepreneurs is really meaningful, so we appreciate that too.
Well, thanks, and thanks for letting me be part of it. Yeah. Really excited and excited about the next 3 years.
I know, right?
Exactly.
Thank you so much. Thanks for listening to another episode, a special episode of Startup Health Now. And we'll look forward to seeing you next time. You can find this and all episodes at startuphealth.com/now. And you can also learn more about the Robert Wood Johnson Foundation program to help underserved communities at startuphealth.com, and pull down in the menu the Entrepreneurship Resource Center. Thanks for listening.
Thank you.